Assalamualaikum warahmatullahi wabarakatuh. My name is Yola Andari. My student number is 22613190. Okay guys, I wanted to explain you about the history and inventor of Omeprazole. First, isotretinoin struck the age. In 1670, recorded within the illustrious family as King Charles is child, Henriette Anne had died abruptly, aged only 26. She had been complaining of stomach distress one day earlier to her passing. Subsequently, an autopsy was performed as hermine was the suspected cause, only to reveal a small perforation on the stomach wall. In 1843, Edgar Trips reported 50 case indication of peptic ulcers. It has been hypothesized since 1880 by Julius Schonheim that abundant gastric acid may result in peptic ulcer disease. The reason for this had not been concluded. At the same time, another theory for the cause peptic ulcer disease was being developed and researched. This hypothesis suggested that there was a bacterial cause for this problem. There were reports of an advancement within the indication of PUD in those taking antibiotics from 1868. However, it was not until 1951 that the primary report antibiotics being used to treat PUD was reported. In 1910, the state no acid no ulcers was coined by Charles Squires, implying that acid was required in a region for the arrangement of an ulcers. In support of this finding, 1954, a study process result which also contraindicated the bacterial hypothesis. Palmer illustrated that by looking at biopsies collected from over 1,000 patients, bacteria is unable of residing in the stomach. Accordingly, it was concluded that the preceding observation of bacteria in the stomach were due to contamination. The driven to the hypoacidity hypothesis being the only credible explanation to cause PUD. Next, the project. Therefore, Ibn Oslam initiated research into potential treatment for this disease in 1967 in Sweden. At the time, he was working for Astra Hasle. He decided to start a gastrointestinal research division with the aim of finding a potent drug for the inhibition of gastric acid secretion to be used in the patient with the peptic ulcers. Having already created productive stomach settling agent arrangement, they started a chemistry program based on carbamates and collaborates with an academic group to develop a suitable in vivo screening assay in rats. Compounds with weak activity were quickly identified. Initial hepatotoxicity problems were overcome, and a potential development compound that was tested in humans in 1968. It had no effect on acid secretion, and the project narrowly escaped termination. Meanwhile, good progress was being made by Smith, Klein, and French in developing histamine H2 antagonists for the same indication, thereby adding to the anxiety with Astra. At the same time, Shirley reported a new class of inhibitor compound, benzimidazole, which were active but toxic. Astra started a new chemistry program based on this arrangement, and in 1973 produced a highly active compound which was proposed for advanced improvement. To their dismay, they found that a Hungarian company had a patent on this compound for a completely different application. However, upon entering licensing negotiation, they found that the Hungarian patent had actually lapsed. because the company had defaulted on payment of the fees to the patent office. Further studies with this compound revealed problems with the thyroid toxicity. Somehow, more demands to terminate this hapless project were barely battled off. The thyroid toxicity was thought to be related with the thiouresil structure, and further chemistry aimed at eliminating this resulted in the forerunner of omeprazole in the synthesis of picoprazole 1976. After yet another toxicological caution, this time vasculitic in dogs, which turned out to be an artifact. Picoprazole was tested in human patients suffering from Zollinger-Ellison syndrome and was found to be highly effective in reducing acid secretion. At around the same time, an academic group showed that acid secretion involved a specific transport mechanism, the proton pump, which was strongly inhibited by the Astra compounds. So, their novel mechanism of action was built up. Omeprazole, an analog of picoprazole, was synthesized in 1979 and was chosen for development instead of picoprazole. Omeprazole was finally approved by United States Food and Drug Administration (FDA) for medical use in 1988. Omeprazole was first marketed in the United States in 1989 by Astra AB. Now it called AstraZeneca under the brand name Losec. That rapidly getting to be the company best-selling Medicaid. In 1990, upon request from FDA, the brand name Losec was changed to Prilosec to avoid confusion with the diuretic Lasix, furosemide. The new name caused confusion between omeprazole and fluoxetine, an antidepressant. When Prilosec United States patent expired in April 2001, AstraZeneca introduced esomeprazole or Nexium as a patented replacement drug. Many companies introduce generics as AstraZeneca's patent expire worldwide, which are available under many brand names.
Assalamualaikum warahmatullahi wabarakatuh. Let me introduce myself. My name is Erlangga Prabowo, and you can call me Erlang. And my student number is 22613. And here I want to tell you about the mechanism of action of omeprazole and its dosage form. So omeprazole itself is belong to the group of PPI drugs. PPI is abbreviation from proton pump inhibitors, which you can see from the name is the work mechanism of PPI drugs is to inhibit the proton pump. What is proton pump itself? So proton pump is one kind of the parietal cell. So its main function itself, PPI, is to decrease your acidity rate in the stomach. So let's take a look at this picture. As we can see here, we have an anatomy of stomach, which here we can see this is a cardia, this is fundus, this is authentic, corpus, and so on. And let's take a look in the corpus here. The corpus is kind of like this, but let's focus in the parietal cell. In the green one here, 1, 2, 3, 4. So the parietal cell is the main topic here. If you take a bigger picture in parietal cell, you can find here It has a microphyllae, which like a silica, also canali, like a blank one here, tubulophilitis, mitochondria, also nucleus, Golgi complex, and lysosome, and so on. So in parietal cell, in the middle of the panel here, we have a proton pump here. If you on the picture, but I have plug it in the main here. The parietal cell here, the proton pump in the middle here, like the circle one here. So in the parietal cell, we have three receptor here: H2 receptor, M3 receptor, and CCK2 receptor. So the three receptor here is stimulated by gastrin. This is one is stimulated by gastrin. This is stimulated by acetylcholine. And the last is H2O is stimulated by histamine. Okay, so when it got stimulated, the three receptor is so the parietal cell will produce an H plus proton. So also it stimulates the proton pump here. We just abbreviate it with PP, and the proton in the parietal cell will conduct to go outside to the stomach. So the proton will be in the stomach. So by the proton H when proton go to the stomach, so the potassium in the stomach will back into the parietal cell. So as you know, in PL, in the parietal, it has already in the stomach. So when you combat, so when the proton H plus bind with the Cl, it makes the hydrochloride. So that's why when we don't inhibit this proton pump, it will make a hydrochloride that it could increase your acidity in the stomach. Proton pump inhibitor itself, it has two dosage form, which is the first is tablets and the second is the second one is the second one. The second is capsule here. So you can see the power is 10 milligram, 20 milligram, and 40 milligram. But if you milk it, you can find 80 milligrams as a powder. So let's just ignore it. So when proton pump inhibitors drug have been activated in stomach, let's draw it here. PPI drug activate. So it will go to the parietal cell, and then the drugs will inhibit the proton pump activation. So that's the problem here. So when the proton pump is inhibited by the PPI, so the proton the expert wrote on here that produced by histamine, acetylcholine, and gastrin, it could not, it couldn't go outside to the stomach, so the hydrochloride will not be made, will won't be made by by the the proton hydrogen H. So hence the acidity here in the stomach will decrease the acidity, but it would increase the pH of the stomach. Okay, so I think that's all from me. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
The conclusion is PPI are prodrugs activated as it were after experiencing an acid catalysis cleavage within the acidic secretory canaliculi of the parietal cell. The most widely used of PPI is omeprazole. Omeprazole is a drug that can reduce the level of acid produced in the stomach. Proton pump inhibitors such as omeprazole tie covalently to cysteine buildups by means of disulfide bridges on the alpha subunit of the H plus or K plus at base pump, restraining gastric corrosive discharge for up to 36 hours. Absorption of omeprazole occurs rapidly, with peak plasma concentration of omeprazole achieved within 0.5 until 3.5 hours. The bioavailability of omeprazole increases slightly upon repeated administration of omeprazole delayed release capsule.
Okay, that's all from me. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.